First things first, this is just a reminder for anyone who's got something like diabetes or another condition, or is on a medication like Plaquenil that has an effect on the retina. You can't see your retina, the other doctors can't see your retina. We really do need you to be seeing either an optometrist or an ophthalmologist just for monitoring, just for safety. Very important to listen to your doctors and follow the recommendation in terms of how often they want to see you.
If you're living in Australia, especially if you're over 50, diabetic, or dealing with sudden changes in vision, chances are you've thought about your retinal health. Blurry spots, flashes, floaters, or sudden vision loss can all be signs of serious retinal problems. Today I'm talking with Dr. Mitch Lee, consultant ophthalmologist, retinal specialist, and co-founder of Eagle Eye Surgeons in Sydney. And we're diving into the critical role of the retina, what can go wrong, and what you can do to protect your sight. We'll explore everything from retinal tears and detachment to intravitreal injections, diabetic eye disease, and the latest in surgical interventions. But first, who am I? My name is Paul Salloway. I'm the owner of Optics Digital Marketing. We're an agency that helps independent eye care professionals to grow their clinics. So, hello, Mitch. Good to meet you online.
Well, thanks for having me on.
Well, in the last couple of interviews I've done on your YouTube channel, I've talked to Dr. Erica Darian-Smith, so this is the first opportunity for us. So would you like to just tell people like the 30 to 60 second lightning round backstory of yourself and your qualifications and how how Eagle Eye Surgeons came about?
So look, I'm a retina surgeon. So this all started, way back when I was in medical school and didn't even know what ophthalmology was. And I was a Sydney Uni student. We all very sensibly were made to spend a little bit of time at the eye hospital just to give us some familiarity with what eye care is all about. And I absolutely fell in love with it from there. I remember, one of my first experiences at the eye hospital was sitting in the operating theatre with one of the retina surgeons over there and just thinking, this is the most amazing specialty I've ever seen. The ability to do these really technically complex but also very quick operations on a patient who is awake but with the eye numbed, put to sleep, calm and relaxed, so that they're not in any pain or discomfort. But it means that there's minimal risk surgery because we're not taking any risks of general anaesthetic. The recovery is so rapid, and we're taking patients from vision-threatening pathology to vision that's good enough to have them driving and going about their normal daily activities. And so just seeing an entire operating list of all of these people who would have been blind without intervention coming out of it with good vision was just amazing. I kind of came out of that thinking, how could I do anything else? So, fast forward, I went through my time as a junior doctor out at Nepean Hospital in Penrith. Got onto ophthalmology training, did my training through the Prince of Wales Hospital Network, and then did further subspecialty training through Sydney Eye, through St Vincent's, through Westmead Hospital. And so after several years of retina fellowships and things, here I am. And Erica and I did our training together at Prince of Wales. We got on really well. We were in the same year group, and we're good friends outside of work. So once we were both qualified, we said, well, look, we both got the same kind of philosophy on medicine and outlook on eye health. And so, why not combine our skills and interests, especially because our subspecialties are very complementary. Erica's very front of the eye, I'm very back of the eye, and both of us meet in the middle with lens surgery. So, we thought it was a good little practice to put together.
Great, excellent. So just to be clear for anyone who's a little confused, the retina is that back part of the eye where like all of the optic nerves sit. Is that right?
So there's your eye. What we're talking about is a retina, which is a light-sensitive film, the light-sensitive film that lines the inside of the eye. So yellow
Right.
stuff on the model. So the eye is like a camera. The cornea and the lens make the image, but it's the retina that's like the film in the camera or the sensor in a digital camera that actually turns that image into something the brain can appreciate. So, as I always joke with Erica that everything up here, her bit is window polishing, whereas this is the bit where vision happens. So
Okay. I'd like to get her feedback on that comment.
you're really angry with that. That's okay.
Well, first of all, I'd like to ask you about retinal tears and detachments. It's something that sounds quite scary, and maybe it is. I really don't know. So, can you tell us, like, what is a retinal detachment, and how does it begin?
So, look, we just saw the model. The retina is like a film that lines the inside of the eye. So one of the problems with the retina is that it's not firmly attached to the wall of the eye. It's on there almost like wallpaper. So
Mm,
there's little proteins and some electrostatic interactions between cells and things that stick the retina to the wall of the eye. And that's really important because the cells that allow you to see, the photoreceptors, need to get nourishment from cells in the wall of the eye.
mm,
Because the retina is thin and fragile, so it's the tissue itself has the consistency of wet tissue paper. It's extremely fragile.
mm,
And yeah, you can get, there's a few different things that can cause it, trauma, changes in the gel inside the eye. There's a few different reasons that a tear can happen. But if a tear in the retina occurs, it allows fluid from inside the eye to get into that layer of almost glue
mm,
sticking the retina down, and it dissolves it away. And
mm,
so, in the same way as if you've got water behind your wallpaper, the retina can strip away from the wall of the eye because its attachments are dissolving away, and the cells that give you vision become damaged in that process. So, a retinal tear, if it's not picked up and treated, can turn into a retinal detachment, which is where the retina's starting to come away. And if the retina that controls the central vision, the macula, is affected by that detachment, then some of the damage to the vision is permanent because when that macula comes away, even when we put it back on, it doesn't work quite as well as it should. So we really want to get in and treat retinal tears before they turn into detachments. And if we've missed the boat on that, then we definitely want to treat a detachment before the macula becomes involved. And failing that, if the macula is involved, if you have a retinal detachment that involves the macula, the vision is terrible. You can barely even see someone holding up fingers in front of you. But we need to do the operation to put the retina back on because we will get some vision back. Won't be 100%, but it'll be a lot better than it is in that situation. And if we
mm.
don't repair it at all, then the vision in the eye will be lost, and in about 10% of cases, the eye itself can be lost. So we always need to treat a retinal detachment, and we always need to treat a retinal tear that we think is going to turn into a detachment.
Right. So it sounds like speed is the essence then, if there are any retinal tears and detachments. So what are some of the warning signs for patients that they should be aware of so that they actually can take prompt action if they do have a tear or a detachment?
So you're right. Retinal tears and detachments are one of the most urgent things that we see in ophthalmology because they're vision-threatening pathology. The things that give you a bit of a warning sign. So to take a step back, the thing that causes a retinal tear in most patients is a process called posterior vitreous detachment. So if we go back to the eye model here, the vitreous is the gel that sits inside the cavity in the back of the eye. When we're younger, it's attached firmly to the retina. That's where it's got important roles in the formation of the eye in babies. But over the course of your life, it just gently comes away from the retina. That's a normal process. In some patients, it can be stuck a little bit firmly in one location than compared to everywhere else, and that might be a little spot out in the peripheral part of the retina. And so when the vitreous is detaching, if there's one point where it's attached a little bit more firmly, you can pull on that point and pull a tear in the retina. So that's how those tears often start. And so the real trick is that the symptoms that people can get from that gel coming away can be exactly the same as the symptoms of a tear. So that gel coming away from the retina is a normal process. It happens to everyone. Only a small number of people get symptoms from it. Those symptoms are things like flashes of light, almost like a lightning strike going off in your vision, or like someone shining a laser pointer at you. It's just a sudden, brief, very bright flash of light that really seems to only be in one eye. And it'll happen, repeatedly. And it often is more noticeable in dim light. And when the eye moves, that can be a trigger for it. So flashes like that are a concern. New floaters, because when the gel comes away, little bits of it can break off and drift around inside the eye, and that's a floater. But if the retina tears, that can also release blood and pigment from underneath the retina that can have the same appearance as a shadow floating around inside the eye. So, retinal tears, process of posterior vitreous detachment can be very similar. So I say that just so people realize that if they get these symptoms, it doesn't necessarily mean that they're about to have a retinal detachment, that it's possible that it's just harmless, but they still need to get it looked at as soon as they possibly can just so that we can make sure that it's not a tear. Because like we said, if we catch them early, they're very treatable. And, better to be safe than sorry. If it ends up being a posterior vitreous detachment and that's it, great. No one's time is being wasted. The doctor that you see is more than happy that you came in and got that checked on, because, we want to prevent detachments and we want to, preserve people's vision. So if you have symptoms, you're worried, absolutely not. You're not a hassle to anyone. Just come to us, come to another ophthalmologist, go to your local optometrist. Someone who can have a look at the back of your eye needs to just check and make sure that things are going okay. If you have a retinal tear, that doesn't mean you need a big operation in hospital. In fact, retinal tears can be treated very easily in clinic with laser. So it is a form of surgery. It's laser surgery. It's different from vision correcting laser surgery. This is laser to stick the retina down around the tear, but that's a procedure that can be done in 10 minutes in my office, without you needing to go and have a big operation and have gas in the eye and all this other stuff. So it's another reason I don't want people to think, oh my God, I've got a tear in the retina, I'm scared to go and have an operation. That's actually what we want to pick up, because we can prevent a big operation.
Okay, that's a good
But
point.
yeah, just so that everyone's clear. I don't want to scare anyone that they need an operation.
So you mentioned about treatments, and I guess one option for you as an ophthalmologist is actually going in and performing surgery. But I believe that another big part of your role is performing injections, intravitreal injections. So these injections sound intimidating to a lot of patients, I think. But can you walk us through what they are and how they help in certain situations?
The reason we do intravitreal injections is that it's a very good way of delivering high doses of medication directly to the site that it's needed. If every other specialty in medicine had as much access to the site that treatment's needed as we do, they'd be doing the exact same thing. Because, to minimize side effects, it's always better if we can get the medication where it needs to go with minimal spread to the rest of the body. And that's what intravitreal injections allow us to do. We can get a very high dose of medication exactly where it needs to be with minimal spread anywhere else, which minimizes the risk of side effects and complications and things like that. So that's the rationale for treating this way. Is it's a much safer way of treating these conditions, and a much more effective way of treating them. The idea of getting a needle in the eye sounds really scary, but ultimately, it's with the injection is done in a way that the eye is completely numb. You don't feel it. It's done off to the side so that you're not looking at it. So again, my handy little eye model that I just happen to have here. People get this horrible idea they're going to have a needle coming straight towards them or something, whereas the injection's actually done on the white part of the eye. And so patients are looking away. The needle is tiny. It's what we call a 30 gauge needle, so about as small as you can possibly get. And it goes in through the white of the eye, directed into the gel in the back of the eye. And so it's not passing through anywhere you can see. My patients will, feel nothing. They'll see a little bit of floaty stuff appear in the vision that then settles over the next few minutes, and that's it, over and done with. So the process that we do for people coming in for injection, we give lots of local anesthetic, lots of drops to make the surface of the eye totally numb. I do a little injection on the surface of the eye, just kind of next to the site, that you don't feel because the eye's already numb by that point. And that just means that the wall of the eye is completely numb. And then, looking away, I lift up the eyelid, maybe once we've given the site a good clean and for sterile purposes. And then the injection is over and done within a minute flat. It's quicker than it's over in a flash. You barely even know what's happened. The most important thing we have with the injections is cleanliness and sterility, because we know that it is a procedure on a body site. It's an injection into a site that's very sensitive, so we want to minimize the risk of infection. So we spend a little bit of time, drops to kill any bugs around the eye. I do a bit of cleaning around the skin again to kill any bugs on the skin or the eyelashes. And then once we're ready to go, I'll just say, look over that side, or look. I give my patients a target to look at. So look over there, hold nice and still. I lift up the eyelid, I do the injection, and it's done.
Okay.
So
Very straightforward.
The people only need to hold the eye still for 5 seconds.
I just want to say, if you're watching this video on the Eagle Eye Surgeons YouTube channel and you're getting value so far, then please hit the like button, because it really helps us out with the algorithm and increases the chances of other people benefiting as well. So Mitch, I'd like to ask you about diabetes or diabetic retinopathy. So diabetes can damage the eyes, often silently. What should diabetic patients know about the risks to their retina from diabetes?
So you're absolutely right. Diabetes is a real scourge when it comes to vision. So diabetes, as we all know, causes high blood sugar levels in the blood. And the problem is those high sugar levels are damaging to small blood vessels. And that happens everywhere in the body, but particularly in the eyes, the retina itself is very, very sensitive to any kind of damage to blood flow. And so when you have that repeated damage over years and years and years, you can get areas of the retina where the blood supply is compromised, and you can get other areas where the blood vessels become damaged and leaky. And so diabetes in the back of the eye can cause little spots of bleeding that don't really impact on the vision. That's just a warning sign to us that the retina is not very happy. But then it can cause new blood vessels to start to grow on the surface of the retina, because the body tries to repair the damage by growing new blood vessels, but they grow in the wrong spot. And they grow on the surface between the gel inside the eye and the retina itself. And the problem with that is those blood vessels are very fragile. They can tear and they can bleed, which can damage the vision because the eye gets blood in the gel. Or they can pull on the retina, because as they start to try to reinforce themselves because the body knows it's a weak point, they get scar tissue forming around them, and they start to pull on the retina itself, and that can cause a form of retinal detachment because it pulls away from the wall of the eye, which requires, again, a big emergency operation. Thankfully, those kind of changes are fairly rare. That's quite severe down the end of the spectrum. But what can happen earlier is if the blood vessels around the macula, which is the site where all of your central vision is, if those blood vessels get damaged, they can start to leak, and that leaking of fluid causes swelling in the macula, which makes the central vision blurry. And so that's the most common thing that I see that needs active treatment in terms of diabetes in the eye. And that can happen quite early in the process, just by bad luck, essentially. And that's one of the things where diabetic patients need injections of medication into the eye to help seal off those leaking blood vessels and relieve the swelling to improve the vision again. And so, diabetes, can be a really difficult condition to live with. It can be difficult to keep your blood sugar under control. So, I don't want anyone feeling like there's any blame there. This is just something that can happen. You can do your best, particularly with macular edema. You can do your best to control your sugar, and you can still end up with this just as a process from the damage that diabetes does to the eye. So, it is quite a common thing that I see, but it's very treatable.
So diabetes, I think, as we kind of know, is fairly prevalent in our society today. But I also believe that age-related macular degeneration, or AMD, is also a common retinal condition amongst older adults. So could you just help us understand a little bit about what causes it and how it's treated today?
That's actually quite a big question, only because we still don't know a lot about exactly what the underlying mechanisms of macular degeneration are. But essentially, as we said, the macula is the part of the retina that does all the central vision. So it's a very central part of the retina. It's where the most in-focus image from the front of the eye arrives. And so that's what gives us our reading vision. That's what gives us our ability to recognize faces, to see text on a page, all that really fine detail stuff. Whereas, the area of retina outside the macula is what gives us our peripheral vision. So the macula is the area of the retina that also has the highest metabolic and energy requirements, because it's where, all of the density of cells and cell activity is happening. And so, as we said when we're talking about retinal detachments, the cells underneath the retina help to provide nourishment to the retina itself. And they do that by taking nutrients and things out of the bloodstream to process and deliver to the retina. And they also take waste products from the retina and send that back to the bloodstream to be processed elsewhere in the body. And our best understanding of macular degeneration is that over time, the membrane in the wall of the eye that allows that exchange to happen. So there's a membrane that sits between the cells and the bloodstream that allow nutrients to come in and allow waste products to go out. And that membrane seems to get clogged up over time in some people. And the problem with that is it means that nutrients have a harder time getting in to get to the retina, and waste products have a harder time getting out. And so one of the markers that we see that tell us that someone might be developing macular degeneration is something called drusen, which is the buildup of waste products underneath the affected area of retina. And so in that early phase, it's there, we can see it, and we can say that someone's developing macular degeneration, but their vision is preserved. But over the years following, the retina itself starts to suffer damage because it can't get rid of its waste products and get new nutrients in. And so the cells start to stop, the cells stop working properly and eventually die away. So the kind of intermediate phase of macular degeneration, the cells are sick, they're not doing their job properly, but the structure of the retina hasn't failed yet, but once we get to advanced macular degeneration, what we call geographic atrophy, that's when those cells have died because they just couldn't keep going any longer. And that's when the vision's quite badly affected. So macular degeneration progresses over years. It never causes total blindness. It won't, take away the vision completely, but it does cause you to lose the central high acuity vision.
So it's actually it kind of manifests as a dark spot in the center of your vision,
Yeah,
does it?
yeah. People
Okay.
often describe like a grey shadow or
Yeah.
a grey blob in the center of their vision that just gets bigger and bigger and more out of
Yeah.
focus. And that's so I should say we always we hear in the media and something about the idea that there's two types of macular degeneration. There's dry macular degeneration and there's wet macular degeneration. What I've just described is what we would consider dry macular degeneration. Now, what I explain to patients is that every person on the planet who has macular degeneration has dry macular degeneration. It just so happens that 10% of those people will get wet macular degeneration as well. So if
Okay.
you have wet macular degeneration, you also have dry. And the thing that makes a difference is that we talked about the retina being damaged by lack of nutrients and that membrane not allowing things across. In some patients, we don't have a good understanding of why this happens. There's a bit of a kind of emergency response that the body has to this situation, and new blood vessels start to grow in through that membrane and start to form a network of blood vessels underneath the retina where there shouldn't be any. And you know, the body's trying to do that because it's trying to deliver nutrients to the site, but those blood vessels aren't really helpful to the situation because they don't work properly. They leak fluid, they leak blood. The retina becomes damaged by that. So they cause swelling and potentially bleeding under the retina. And in really severe cases, they can rupture and cause what we call a subretinal hemorrhage, which is where blood pools underneath the retina and that wipes out central vision immediately. And so that's why in the old days, before we had treatment for wet macular degeneration, it was viewed as being the worst type because it could damage your vision very, very quickly. Whereas now, with those injections, we have medications that are so good that we can effectively reverse the wet component and keep it completely at
Mm.
bay. But the reason people aren't cured by that process is that they still have the dry macular degeneration ticking along underneath it. And we don't have a good curative treatment for that yet. There's some new stuff coming on the horizon, which is really exciting. We've got some new treatments that we're hoping become available in the next year or two that should be able to slow down progression of dry macular degeneration, but we don't yet have a treatment that's as good as we do for wet.
Mm. Okay. So the treatment for the wet is that what they call what is it? Anti-VEGF, is that it?
Yep. So the anti-VEGF medications, that stands for anti-vascular endothelial growth factor. So remember I was saying that, the sick retina puts out an alarm signal
Mm.
that starts to cause blood vessels to leak and cause new blood vessels to form. That's this hormone called vascular endothelial growth factor. And so it's released by tissue that's lacking blood supply, and it's the body's way of knowing where it needs to grow new blood vessels. It's the same stuff that's released in a diabetic eye when there's damage to the retinal blood vessels. And so it's just about where that release of mediators is coming from. And in macular degeneration, it's happening at the level of the wall of the eye. That's why the new blood vessels form under the retina. Whereas in diabetes, the damage is to the inner retinal circulation, which is on the inside of the eye, that's why the blood vessels grow on the inner surface of the retina, not out near the wall.
Okay. Okay. All right. Well, so there's one more retinal condition that I want to ask you about, and that is retinal vein occlusion. So I think that's maybe a term a lot of people aren't familiar with, yet I believe it's also a pretty common cause of sudden vision changes in adults. Can you explain what it is and what happens inside the eye with the retinal vein occlusion?
I'm really glad I brought my little friend here. This has been really useful. I think if you can see on the camera there, you can see, so this is the optic nerve there. The optic nerve is where blood vessels enter the eye. So the blood vessels that give you circulation inside the eye enter from that point there. There's a bit of a design flaw in that the arteries and the veins come in sharing the same connective tissue tunnel that allows them to come
Mm.
into the eye, and they cross over each other as they kind of head different directions. And so at each of those crossing points of an artery and a vein, you've got a bit of a weak point there. And so retinal vein occlusions, the most common cause of retinal vein occlusions is high blood pressure. Because the pressure
Mm.
inside the artery becomes so high that the artery squeezes the vein shut at that pinch point, you can get a
Mm.
little bit of a blood clot forming that blocks the vein completely. And so
Mm.
that stops blood from leaving the area of the eye that's supplied by that vein. And so if it's what we call a branch retinal vein, so a retinal vein that's out in the peripheral part of the eye somewhere, then it's just one area of the retina that becomes affected. But if it's the central retinal vein where it's going back into the optic nerve, then that can affect the entire retina and affect the vision generally. So, vein occlusions, it depends on where in the system they are, but the effect they have is the same, which is that blood can get in, but blood can't get out properly. And so what happens there is the pressure inside the veins and capillaries and arteries in the eye rises, and you get damage from blood vessels starting to leak, and you get damage from the retina not being able to get the blood supply it needs because the flow is interrupted. So it's usually not as severe as a retinal artery occlusion, which is like a stroke, effectively, where blood can't get in. But this has a similar effect in that it interrupts the blood flow, and vision is lost because of damage to the retina from a lack of blood supply.
So what are some of the treatments available to reduce complications when something like this occurs?
So we think about this in terms of what we need to do for the eye and what we need to do for the body in general, because the risk factors that central retinal vein or any kind of retinal vein occlusion have, they share those risk factors with other cardiovascular diseases. So, the major risk factor that we worry about, like I said, is high blood pressure, but it's also fed into by things like diabetes and high cholesterol. And in very rare cases, it can be because of inherited clotting abnormalities. That there are certain people who are predisposed to getting things like deep vein thrombosis and pulmonary embolism that can also get retinal vein occlusion. That's why we need to think about the patient in as a whole rather than just thinking about the eye. So, for me, when I see a patient with a vein occlusion, the first thing I'm thinking of is what could have caused this. If it's someone who's in the correct age group, so someone older than the age of about 50, who's got a history of high blood pressure and maybe where it's very up and down, then that's very open and shut. We know what the cause is and we can treat that. Just the same if it's a person who's got forms of glaucoma and their intraocular pressure is a bit out of control, that can do it as well. But if I'm seeing someone who's, say, a 34-year-old woman who's got no other risk factors, then that's a bit of a red flag to me that maybe this isn't just your standard vein occlusion. Maybe this is actually something that's related to a clotting abnormality. And so, we tailor treatment and our investigations things a little bit to the patient who's got the problem, as we all should as doctors. But so, step one for me is always, what do I need to do to keep this person safe from other diseases that could affect the eyes or could affect the rest of their body? And then step two is what do we need to do for the eye? And so in terms of the eye, if there's no effect on the vision, then that person may have gotten very lucky that the vein occlusion hasn't affected a part of the central vision, in which case we may be able to just watch and allow the body to clear the blockage by itself without needing to do any active treatment to the eye. In some cases, though, the blockage affects the macula, and we can get swelling in the macula, much like we can with diabetes, in which case the treatment is the same. We do injections to try to settle that swelling down, knowing that the body will eventually clear that blockage on its own, but we need to protect the vision as much as we can while the body's doing so, because if we allow that swelling to sit there unchecked, there can be permanent damage to the retina before the body's able to repair the blockage on its own. And in some cases, we can get forms of new blood vessels growing, again, similar to diabetes. And in those cases, a combination of injections and or laser to get rid of those damaged vessels is the correct treatment. And in some rare cases, a vein occlusion can be so severe that it very badly damages the vision in a way that we can't fix, but also starts to cause a form of glaucoma, because you get new blood vessels growing in the front part of the eye that can put the pressure up, and that can result in an eye that doesn't see but is also extremely painful. And so we will sometimes be doing injections and laser to treat that condition, so that even though we might not be able to salvage a lot of the vision, we can allow someone to keep their eye and have a comfortable eye that still sees something.
Okay. Well, Mitch, so this has been a gold mine of information. I think, with the assistance of your trusty eyeball model there, I think you've explained a lot of things about retinal eye health in a way that, we can all understand much better now. Um, Before we wrap up, is there anything that you'd like to tell people about what they should do if they're at all worried about their retinal health?
First things first, this is just a reminder for anyone who's got something like diabetes or another condition, or is on a medication like Plaquenil that has an effect on the retina. You can't see your retina, the other doctors can't see your retina. We really do need you to be seeing either an optometrist or an ophthalmologist just for monitoring, just for safety, because, there's a lot of things that we can see and we can intervene on really early before they cause problems, but we only know about them if we can see them. And the only way to do that is to get someone in the examination chair and have a proper look at them. So, for any of those conditions, really important for eye health. Even if you don't have any symptoms, you think everything's going okay. Very important to listen to your doctors and follow the recommendation in terms of how often they want to see you. And then for anyone else who's got symptoms or who may have been told in the past that they might have a retina problem that needs monitoring, something like epiretinal membrane or something like, a retinal hole or a tear or something like that, then yeah, if you've got something that you think you need to see a retina specialist for, we at Eagle Eye Surgeons have locations in Mossman and in Penrith. So I'm the head of department for Nepean Hospital Ophthalmology. So we've got a location out that way as well, just next to the public hospital there in the Nepean Health Hub. So yeah, very happy for you to get in touch. You can see your GP or your optometrist for a referral and come on in and we can have a look and check to make sure there's nothing worrying.
All right. And that's a good segue to perhaps you can tell us how can they get in touch with you there at your clinics?
Sure. So we've got a website, eagleeyesurgeons.com.au. It's probably a really easy way to find us. Otherwise, by phone, 7228 3900 is the number for both clinics. So for that number, give us a ring, let us know where you're located, and we can tell you what clinic might be closest to you. We can get you in for assessment.
Excellent. All right. Well, if you found this interview helpful, then please don't forget to like and subscribe and stay tuned for more expert conversations like this one. Also, follow Eagle Eye Surgeons on their Facebook and Instagram accounts and visit their website for updates on treatments and further patient education. Okay, well, thanks very much, Dr. Lee.
Thanks, Paul. Next time I'll talk your ear off about retina surgery or something. It'll be good. It'll be good.
Look forward to it. All right
See
then.
you
Okay,
later.
take care,
Thanks.
everyone. Bye for now. Bye-bye.